basically today I welcome you all for today's conference. What was there in my mind to do revisit the common cancers which are there. We are dealing every day, and during our busy practice, sometimes it is not easy to read or follow through. So by this presentation, we really brush up our thought processes as far as treatment of patients are concerned. So basically, I've chosen two cancer, one above the diaphragm and then below. Above the diaphragm, basically, we are concentrating on lung cancer. And below the diaphragm, there will be topics on HCC as well as the bladder cancer. So as we know that these lung cancer is the most common cancer. It is difficult to treat. Nowadays, new biomarkers have come, new targeted therapies have come, and still, newer and newer therapies are being started in this, and sometimes it's difficult to follow how much new treatment modalities have come in this, and even biomarkers, newer and newer biomarkers are coming every day, and we have targeted treatments for those biomarkers. So basically, the first topic will be by Dr. Bharat Vaswani. As we know that he is a senior medical oncologist, is fairly known throughout our oncology fraternity. He's a medical oncologist and hematologist at Yashoda Hospital. So I'll request Dr. Vaswani to start his topic. Basically, I request all the speakers to stick to their timing because topics are very in numbers are very high. So Dr. Vaswani, please.
Good evening, sir. Thanks for the kind invitation. Sir, clearly audible, sir?
Yes, audible.
Yeah, so. One minute, I've lost my screen. 1 minute.
Lately, I'm finding difficulty in.
Yeah, I'm not. I'll stop here and see. Once give me 1 minute. So where is that? Give me 1 minute, and I'll open this. Where did it go? Escape. Sorry, actually, I'm not able to share screen. Give me 1 minute. I will pick my presentation. Launch share 1 minute. My PPT is not coming, na, sir?
It is not there, but I think you're pressing on that PPT. That's what we can
see. It is not way. I'm also pressing it. Your screen sharing.
Sir, your screen is visible.
Yeah, I'm able to see actually, but that slides are not actually. Give me 1 minute. Should I come back and rejoin? Should I do like this?
Sir, if you haven't made any changes in your slides,
I have made everything. Yeah, what you gave is absolutely everything I changed. So there was no. Give me 1 minute.
Okay.
Give me 1. I'll go out. Up share. I'll go back. Give me 1 minute. I'll come back. Yeah. What? Yeah.
Yes, now we can see.
Sorry, sir. Sorry for absolutely.
Not done, please.
Apologies for this. Sir, so the topic that has been given actually yesterday only for me that I have things. So, but I try to make it interesting. What is emerging biomarkers for metastatic non-small cell lung cancer? Every marker I have put only one slide. So for your practice also, you cannot go through these slides again and again. The gist of all biomarkers, a single study which has been given, and what is the outcome that I have mentioned. Probably it will be helpful for you to remembering, and when you want to re-revise this topic, it will be easier for you to re-revise. So when I talk about lung cancer, I think so a cancer probably with where the treatment has undergone a paradigm shift from a disease called as when we used to treat like adenosquamous. Now we have multiple biomarkers, more so in adenocarcinoma. In fact, 50% of all de novo adenocarcinoma, metastatic non-small cell lung cancer will have a targetable mutation. And I'll go one step further. If you are a never smoker and a female, probably this targetable mutation may go up even up to 80 to 90%. So every one of us know that it is mandatory now to do this biomarker testing on day one, and you may even repeat it over a course of time to see what new mutations are coming up. So by doing this approach, the main thing is what is the advantage? So that was answered by a lung cancer mutational consortium, 733 patients for 10 genes. What they observed was when you give a patient a targetable drug based on the genomic alteration, there was a statistically significant improvement in overall survival, and the median survival was 3.5 years. So for the first time in what we say in all comers with a targetable mutation, you are able to achieve your overall survival of more than 3 years, as against chemotherapy where you remember it is around maximum 12 months, or it can still go up to 18 months. EGFR ALK, these are common, and I have been told not to discuss EGFR ALK. So what next? So there are 8 alterations that I'll be putting one slide for each of them. EGFR ALK, then comes a ROS mutation, then came a BRAF mutation, then came a EGFR. Please remember EGFR exon 20. You need to understand there are 2 things: EGFR exon 20 insertion and HER2 new exon 20 mutation. Both are exon 20, but it is important because the drug is different. There is a RET, anti-RK, and a KRAS, which is a new molecule where we have 2 new exciting data available about. So when we talk about it, there are around 15% of the patients who are having these uncommon mutations, and that is a target of my today's discussion. This everybody knows that lung cancer is not a single entity. We tell our patient that let us wait for a molecular alteration and then we can prognosticate, tell them everything. So there is not a single disease, but multiple molecularly driven disease in encompassing in the single, what we call as a lung cancer. So a moving target. Now, what are the biomarkers you should remember apart from EGFR? So ROS, BRAF, RET, MET exon, HER2 new, KRAS, and TRK. Please remember, whenever you do your NGS profile, if you are doing a comprehensive, nothing like it. But even if when you do a hotspot, make sure that this 8 and or 9 alteration should always be covered. You may not give a drug, but it can prognosticate also, because if you have a MET exon 14 or if you have a mutation called as BRAF, the overall prognosis is also slightly bad. So indirectly, you can prognosticate your patient if you have a driver mutation present or not. What do our guidelines say? So most of the guidelines concur with what I have said. Is it is now mandatory to do this 9 alteration in all de novo metastatic non-small cell lung cancer. In fact, even in squamous also we have started doing it, because I have few patients who are MET exon 14. In fact, in a never smoker, or when we say 2 types of disease where it is adenosquamous, you should do it. But most of the time we have started doing in all of our patients, not for EGFR, but other alteration like BRAF, which is also present in squamous cell type. Rarely MET exon 14 also I have seen in my patient. So let me start with this 8 alteration in a single slide. ROS1, this is something that because we have a drug called as crizotinib, we are doing it. Now, the thing is, which type of patient should be chosen? Again, young, never smoker, and lipidic type of thing. This is important also, as I will be discussing in MET exon 14, that is sarcomatous type, mostly presenting with advanced stage, a higher number of brain mets. So we have 2 drugs available now. Which is the best way to do it? Actually, we used to do it with IHC. Please remember, ALK and ROS, you can do it by IHC, but in ALK, you don't have to do a FISH again to confirm it. But here, if you are doing your ROS mutation by IHC, it is mandatory to be confirmed by FISH in this case. So NGS definitely a gold standard. This will I will be always be discussing about it. We have gone ahead and do the NGS, but again, when you do NGS, it takes 2 weeks, and when you do IHC, it takes a day. So when you want the report urgently, probably IHC is the way to go. But again, IHC has to be confirmed by FISH when you say it is a ROS. Right? Now, this is important slide. 2 drugs, Chryso. At present, it is a no-brainer. You need to give Chryso. The good thing about it, compare your PFS in ALK and ROS in Chryso. 10 to 11 months. Here, Chryso has a PFS of 19 months. So whenever you tell your patient and when they start on Chryso, this PFS is very good as compared to ALK rearrangement with a very good response rate of 72. I would like to point out toward the waterfall club also. Majority of patients will respond, not like a PR, but even less than PR. So this stable rate may go up to 90%. Entrectinib, we are waiting for it, probably slightly better and covers more of a time, but at present, no other brainer. Now, in future, we'll have these 2 drugs available for this. Repotrectinib. So probably this drug is also an advanced anti-RK also. So this is a good drug. The advantage, and you will see, take my word, in future, repotrectinib might become the best drug even in ROS because it covers that potent G2032. Remember, ALK is different, this is different. So the mutation which you commonly get with Chryso, that is covered by repotrectinib also. So probably this will be a go-to drug, and whenever it is available, it may become a first-line drug in ROS, and a new drug called LVM520. So ROS 1 to 2%, and Chryso at present, future is bright for repotrectinib. When we talk about BRAF mutation, again, BRAF mutation 1 to 3% mutation, but more importantly, V600E, that is mutation that we target. What about non-V600E? No definitive data, but some data about trametinib. How to find out? Older days PCR. Now we are doing a NGS test. Important thing about dabrafenib and trametinib. So again, try to look into all the 3 things. Look at the waterfall plot also. Although it may not be a PR, but it is less than, but there is a response. Again, hardly 1 or 2 if you see it is above the curve. So a very good response rate of 64% with a PFS of 14.6 and a median overall survival for 17.3. Although FDA has approved it as a second line following failure of first line chemo, but again, with the impressive data in the first line, probably we need a phase 3 registration. Because of the rare mutation, we may not get it, but a good drug with Dabra and Tremi. Now, a question that I'll be answered: what about a single agent Dabra, or you need to combine with Dabra and Tremi? So when you look into it, there is an obvious improvement in overall response from 33 to 62%, and an improvement in PFS from 5.5 to 9.7. So whenever you think of dabrafenib, please give Dabra with tremitinib. Second thing which I have not covered is, what about toxicity? So please remember, it is the other way around. Single agent Dabra may have more toxicity than a combination of Dabra and tremitinib, and that is a thing which we need to remember. So whenever you choose it, it is a combination to be given. So second, BRAF, yes, whenever available, the PFS is quite impressive, 14 months with a very good survival rate. So, but at present, FDA has approved it as a second line following failure of first line. Now comes MET exon 14 skipping mutation. Again, whenever you think have a disease called what we call as carcinosarcoma or sarcomatoid carcinoma, please rule out your MET exon 14 skip mutation. Please remember, now with RNA NGS also available, we used to do DNA, but now our newer platform contains RNA. This is something that we are seeing more commonly. We have two impressive drugs which are available. So I'll go back. So again, 3 to 4% more commoner than ROS and BRAF. Elderly females, and we have two drugs called as capmatinib and tepotinib. Again, which is the best platform to do it? So whenever available, this is the pickup rate is better with RNA NGS than a DNA. As a short, when you think of mutations, think of DNA. When you think of amplification and fusions, think of your RNA NGS. Now, two drugs, capmatinib, tepotinib. Now, when you look into this drug, probably when you see is capmatinib is probably a slightly better drug than tepotinib. 63 versus, if when you say 44, 12.6 versus 11.1 and 12.4 versus 11.5 in PFS. I have used capmatinib. Again, more importantly, when you give capmatinib, prepare for peripheral edema because most 1 and 2 will have some degree of peripheral edema, a MCQ question, a class effect, some degree of GI toxicity. So again, when you compare this with your chemotherapy drug, again, these are better off. These are slightly better. 12 months PFS, you don't get with chemo in metaxon, 6 to 7 months is there. But again, it has not been approved as a first, but second line following failure of chemotherapy as per as FDA guidelines. What about now? I'll be covering two exon 20 insertions and HER2 new exon 20. So the most common is about insertion, not as uncommon. 4 to 10% of all EGFR mutation will be exon 20 insertion. Important, the EGFR TKIs that we use may not work well. We have some data of double the dose of osimertinib, remember 160 mg, but overall survival and PFS is poor as compared to the exon 19 and L85R exon 21 mutation. Again, NGS PCR not sensitive. Two new drugs that has come. I'll be telling one slide, mobocertinib and amivantamab, which we have from Johnson & Johnson. When you talk about mobocertinib, the data is good, but not as impressive as amivantamab, 28% response, 7.3 months PFS and overall survival of 24 months. Please remember, even exon 20 insertions are not equal. There are multiple types of exon 20, and it is important what type of alteration you have. You have an insertion or some other thing, in-frame mutation. When we talk about amivantamab, a better response rate of 40%, 8.3, and close to 2-year survival. Now, when you look into the right side, whether you have given previous EGFR or not, or whether you have given immuno or not, the response rate or the remains the same. So you can easily use the drug following second line also. Probably for me a slightly better drug, but please beware of the side effects also. Infusion related reaction 66%, 4% discontinuation. Over a period of time, we learn how to use this drug. Then come the second part of presentation, and this is something that we need to remember. Please read not only exon 20, whether it is ERB2 or an exon 20 insertion. The best way again is NGS, probably better than a PCR, and its pickup rate is better, 1 to 4%. Till now, since 6 months back, we used to say we can give chemo with trastuzumab, which is also not proven. TDM1 in ARB2 exon 20 mutation, against TDM1 does not have a good data. The only data for ERB2 is trastuzumab deruxtecan. This is a new data, a response rate of 55%. Again, see our waterfall plot, very good, around 90% disease control, 8 months and 17 to 18 months of OS. So at present, only drug which has really shown a benefit in this ERB2 exon 20 mutations is deruxtecan. We may use other drugs, but this data is not impressive. So the 6th type is red. This is probably a drug which has the best response rate if you see in the PFS. Again, 1 to 2%, also used in thyroid cancer, young never smoker, NGS. Again, rearrangement, fusion, RNA is slightly better. Selpercatinib, prelicitinib. Now look into two pivotal studies, ARROW study and Liberto study for selpercatinib. Treatment name, impressive PFS. In fact, and Liberto, if it is nearly 2 years of PFS. 2 years of PFS probably is the best. We see in some of the EGFR type and definitely help, but 2 years of PFS when you use selpercatinib in the first line. Even in a second line, when you look into it, 16.5 months with prelicitinib and 24.9 months with selpercatinib. So probably here, I think there is no brainer. Whenever you have this drug freely available and when you have a RET. In fact, there is a Roche program going on for RET. So whenever this drug is available, I think it will be far better than giving a chemo option. But both drugs, any of the two is good. First line close to 18 to 24 months of PFS. OS has not been reached. Then comes the rarest but the most discussed mutation, anti-RK. At least I have seen only in one patient in the last 5 years. Again, NGS, again, a RNA NGS, that is the best form of it. There are multiple drugs now available for anti-RK. First generation larotrectinib, 83% response rate with a survival close to 3.5 years, and entrectinib again reaching the same figure. So probably whenever this mutation is there, probably these are better drugs. Now we have second generation anti-RK inhibitor also. And please remember, repotrectinib that I was discussing in ROS also. Probably this is a second generation, a very impressive data, and probably here also, once this comes, probably this will be a go-to drug for ROS as well as anti-RK. The RAS mutation. Again, a NGS, probably here DNA NGS because it is a mutation. 25% of all CA lung are KRAS, but out of half it is G12C, where we have two drugs available, sotorasib and adagrasib. A drug which I have used recently, unfortunately, that came post, that was an exon 19 progress and then developed a G12C. And so I added a sotorasib. 8 tablets we give, dose is 960 mg. The important thing is when you look into the response rate as compared to dosi, better, 28.1. But the overall survival is only 11, which is as good as dosi. The problem is a toxic drug with a higher grade 3 diarrhea and liver abnormality. When you look into interruption, 36%, 10% discontinuation. So probably you have to be judicious when you use this drug, and probably the better use of drug, I feel this OS will be better because there was so many disease interruption and the drug was stopped in multiple patients. A new drug, probably adagrasib, not a new drug, but yes, it was used in colon, and now then I go back and see the response rate is better than sotorasib. The PFS is as good, and OS again is as good as sotorasib. So probably at present, nothing to choose between the two. The side effect profile important. GI side effects is very common. So you have to be careful when you use this drug. Again, for every class of drug, there is a class side effect, and we have to be careful and we should know it before we use it. So I have told you about 8 rarer drugs available. The response at anywhere is from 50 to 80%. If you remember, the PFS is between 7 to 12 months, except for RET fusion. What to use? NGS, I think it is no-brainer. Unless you need the report very urgently, you can go ahead and do IHC as well as EGFR when you do PCR, when you get a report in 2 to 3 days. But probably if the patient is stable, you can wait for 2 weeks. I think NGS is better. Tisuprofene, resorprofene, so probably all the advantage at the end. The pickup rate is better, and you can pick up variant alleles. The most important slide. Why do you need DNA and RNA both? Because for some, like mutation, deletion, insertion, DNA is better. But for fusions, probably RNA is better. For ROS, RET, and anti-RK. So probably a NGS which contain both DNA and RNA is the best one. What about immunotherapy? Actually, nothing to discuss about immuno. They have given me slides, so I have just put these slides. PD-L1 by TPS. Please remember, in other cancers, it is PD-L1 by CPS. For lung, it is PD-L1 by TPS. So it is a tumor proportionate score that we see here. That is what I said.
Dr. Bharat, kindly conclude in the next 1 minute.
I have only 30. So should I do a TMB? So the answer is yes. TMB should be done when you are using a IO-IO. The moment you use IO-TKI, probably TMB is not the way to find out whether the drug will well. So Ipi-Nivo, see your checkmate 227, TMB is a very good. So PD-L1, if it is chemo or combined with IO, and when you are looking for IO-IO, probably TMB is a better way to judge whether it will work or not. Now, this everybody knows. Now, current standard, this also more than 50 single agent, but if it is a never smoker female, probably add chemo even when it is TPS is more than 50, less than this, chemo with IO. Now, whether there are two things which already has been discussed, whether you can predict whether IO will work or not. So again, this was more for the atezolizumab study, where if you have a STK11 mutation or a KEAP1 mutation, probably in that scenario, IO may not work well. So probably in future, probably with the increased use of these markers, we may tell in which patient you should not give your IO. So these two mutations confer worse outcome in immune checkpoint inhibition in patients who are KRAS mutant, but not in wild type. So probably these two mutations will be looked for, or we have started looking for it in future. So if I have to summarize again, there for everyone, and probably this is nothing to be told, biomarker testing is mandatory for metastatic non-small cell lung cancer because we have so many new targets available, and based on that target, we have drug, and at the end of the day, the overall survival is increasing. So increasing role of pathologists available. Most importantly, we should preserve the tissue and use the tissue judiciously over a period of time. Only drawback I can say is it takes a lot of time to get this report. So at least 10 to 14 working days by getting an NGS. But over a period of time, probably that is something which we need to improve. So if I have to summarize my thing, lung cancer is probably a disease of all molecular genomics. You do a molecular test and everything right from start to end depends upon what are the molecular alteration. And probably in future, we'll have new targets coming up well, and based on the new target, we'll have a lot of new drugs available. So we are in for an exciting time. I thank you all for a patient here.
Thank you, Dr. Vaswani. That was a wonderful presentation of rarer mutation. We read for common mutation, but rarer is very difficult. And now we have so many targeted therapies. Very good target. We need to find, more effort is required to make which is a better target where we can give immunotherapy. Thank you very much for a lovely presentation, and we move on to the next session. Now I request Dr. Ashwin Philip. He's a senior consultant, Department of Medical Oncology in Christian Medical College and Hospital in Mohandas Oswal Hospital, Ludhiana. Now he'll be talking on managing stage 3 non-small cell lung cancer. Dr. Ashwin, please.
Yes, sir. Is my slide, can I be allowed to upload the slide from my side?
Yeah, please.
Just let me know if you can see the slides. Have they come?
Yeah.
Right. So at the onset, I would like to thank Dr. Rajeshwar for giving me this invite. Always a pleasure to be a part of these academic events. So I'm here to discuss about managing stage 3 non-small cell lung cancer in the real life setting. And we look at it as a case-by-case discussion of a patient who comes to an OPD with the typical complaints of cough, 52-year-old male, and has no comorbidities. And an X-ray done shows a left upper and middle lobe opacity. And this patient gets evaluated further. So a CT scan is done like in everything in the real world scenario. What you see in a CT scan is a large heterogeneous lesion in the apical posterior segment left upper lobe lump, which could be neoplastic, and there are a few subcentimetric and enlarged mediastinal lymph nodes. So a CT scan is done, and then a PET scan is done, which you can see clearly shows you a large 7 into 7.58 centimeter lesion in the left upper lobe of the lung. You can see this lesion very well over here. And this lesion is abutting the mediastinum, so that becomes a T4. It is abutting the arch of the aorta, encases the left upper bronchus, and there are mediastinal lymph nodes. And these mediastinal lymph nodes are bilateral. So it becomes an N3 disease as per imaging. So what happens is that in imaging, biopsy is done, shows you adenocarcinoma based on IHC, which is TTF1 positive, CK positive. And you have a clinical picture of a T4, N3, N0. The mediastinal nodes have to be evaluated. So this puts an important thing in the question is, do we require mediastinal sampling for all these patients with a T4, N3, N0 disease? Right now, with so much of interest that is coming back to the cardiothoracic surgeon and people who are trained in lung cancer surgery, there's a lot of interest in resecting these borderline resectable diseases. That is N2, low volume N2, less than 2 centimeter N2, less than 3 centimeter N2 borderline diseases. So one of the biggest things that you face today is who is surgically resectable and who's not surgically resectable. When I was training, not a long time back, in Adair, I was happy to see a lung cancer that was metastatic because that was the end of the story and we didn't have to talk to anybody. But whenever there was mediastinal lymph node involvement, it was a bit difficult to plan a treatment. And most of those patients in our setting went on to get chemo radiation because they were not fit in one sometimes. So your absolute contraindications of surgery is performance status of the patient, poor pulmonary function test, N3 nodal disease, T4 disease is considered an absolute contraindication for surgery. But now with this newer data coming in with the use of neoadjuvant immunotherapy, the borderline resectable N2 diseases are now considered important. So even if you look at it from that point of view, those patients need to get a complete remission after you get neoadjuvant chemotherapy. And prior to that, most of the studies which looked at newer induction chemotherapy followed by the role of surgery, none of the studies actually showed a survival advantage by doing induction chemotherapy and followed by surgery or direct concurrent chemoradiation. It is now with the era when you're going to give immunotherapy, there is some margin of benefit and people are talking about it. So that ultimately every lung cancer patient now today is becoming exciting. It needs to be discussed in a multidisciplinary tumor board, and your team of doctors should be capable and be able to understand all these things and offer a proper comprehensive surgery if it is possible. The discussion is made right at the beginning, not later down the treatment. And now with the new NCCN guideline, you have stage 3 split into A, B, and C. And that even makes it slightly more difficult. And you've upgraded those tumors, which are more than 7 centimeters, into a T4. So all these things have made a difference. But now it is so important to understand your pulmonary, the nodal stations, which as an oncologist in the beginning of my career, I found it very difficult to understand. So that is an important thing for us now to understand when we treat these patients to take the response. So if you look at it traditionally, the 5-year survival for those patients who are clinically stage 3B and 3C have been around 26 to 13%. If it's a clinical, if you look at the pathological, it's around 24 to 12%. So traditionally, they have been poor and the treatment has not been very well defined. So anybody who has a mediastinal lymph node positivity, N2 disease was considered, was initially usually considered for patients with chemoradiation. So that is what the bulk of the data would suggest. Now, when we work up these patients, yes, you have to do an MRI technically, even though in a real world setting, if the patient is fit, doesn't have neurological symptoms, sometimes we don't do an MRI, but technically the guideline says get an MRI done, make sure there's no metastatic disease before you proceed with your treatment. Now, if you look at surgical staging, mediastinal staging versus non-surgical staging, with the event of EUS and EBUS, it is reasonably easier, safer to do a staging and look at the mediastinal lymph nodes. The guideline even now says if you have a clear-cut N2 disease right at the beginning, you can directly proceed to chemoradiation and evaluate the patient later. In those patients who are doing mediastinal, you may planning for surgery and who don't have occult, who turn out to have an occult N2 disease. If you're planning for the surgery, guideline says you may consider completing the surgery or withdraw the surgery and go on for the for chemoradiation. So these are slightly tricky. So I would always prefer a less invasive non-surgical evaluation by EUS and EBUS, and definitely the patient has a PET scan done, and if there's a chance for a surgery. So that is very important. You have to determine upfront whether this patient will be fit for a surgery or not, and that has to be discussed in a multidisciplinary tumor board. I mean, a lot of time I go for these meetings, everybody discusses a lot of things, but ultimately the plan should be very clear whether the patient is fit, comorbidity-wise, performance status-wise, pulmonary function-wise, to understand, to go, then you discuss the entire thing in the tumor board and then plan a treatment and then make sure that he's whether T4 whether a complete resection can be done at some point of time. So that is important. Otherwise, I don't think there's any role of doing a EUS, EBUS just to prove it. So all these things have to be taken into account before you treat these patients. Now, when it comes to staging, yes, a PET scan is now considered standard because of the increased sensitivity and specificity to doing a PET scan in return in terms of mediastinal staging that has been proved. Now, if you look at invasive staging and the role of an invasive staging, you need to understand that there's enough data to show that you can go less invasive. Like I initially said, mediastinoscopy and all those. So you can use EUS, EBUS, and the combination of EUS, EBUS now increases the specificity and sensitivity from 81% to 91 to 100%. So that is reasonably good, easy, safer to do, and an OPD procedure. Now, we're exclusively talking about stage 3, where the standard of care right now is concurrent chemoradiation followed by consolidation with immunotherapy. Initially, when before immunotherapy came into the picture, these patients used to be considered for concurrent chemoradiation. There used to be enough discussion between what chemotherapy you should give, etoposide cisplatin versus paclitaxel, whether we should give 2 doses of consolidation with paclitaxel followed by when you finish the chemoradiation. So that was always a bit of a confusion. There were toxicities that were coming in. So that is what we'll be discussing right now. So when you take a decision, this patient is unresectable, is not for a surgery, then you plan for chemoradiation. And the aims of your treatment is local regional control and systemic control as well. So that is why you need to be sure that the brain is clear and there are no sanctuary sites in any part of the body. Now, this patient has a T4 N3 stage 3C disease. The T4 is because, as I mentioned before, it is 7 centimeter, touches the mediastinum. N3 is because the contract lymph nodes are involved on the PET scan. And yes, he's a young patient, so definitely we will talk to the cardiothoracic surgeon who's capable of doing lung resections. Another thing that is important is if you look at the data, if you're planning a lung resection, that patient should be coming under the criteria of doing a lobectomy, not a pneumectomy. Those patients who go for a pneumectomy tend to have worse survivals and worse outcomes compared to the patients with lobectomy. So all these things are very important when we plan a patient. I do not have a lot of experience dealing with these patients who are going for surgery. Most of my patients in my setup would undergo chemoradiation, but the more we discuss this, the more I understand that these things have to be taken into account, and the surgeons have to be discuss all these things, whether a lobectomy is possible or a pneumectomy is possible. If a pneumectomy is the treatment plan, then the benefit of doing a surgery is much lesser than what would be for lobectomy. Now, coming to the important role of this patient, was planned for chemoradiation, cannot come weekly, initially has an issue. So starts with induction chemotherapy and gets it on day 1, day 8, day 15. In my practice, if the patient is fit, I would definitely give chemoradiation, not induction, because most of the trials have shown that sequential chemoradiation is not beneficial. And if you have to give it, it's always better to be concurrent chemoradiation if the patient is fit. But in a real world, again, you will have to tweak your practices based on what the patient requires and the situation that demands it. So this patient then, after getting 3 rounds of induction chemotherapy, shows a partial response. And why this is important in the real world is that if you look at the Pacific study, which is what we're going to talk about, is around 26% of these patients had got induction chemotherapy at some point of time, and then they went on to get concurrent chemoradiation. So that shows you that yes, in the real world, these things happen, and that is an acceptable part if you're going to give, if you're planning to use durvalumab in your patients. So this patient then goes on to receive concurrent chemoradiation with IGRT, and he treats it and he tolerates it well. So right now, the standard of care is to give concurrent chemoradiation in a stage 3, which is unresectable disease. And definitely concurrent is better than sequential. The patient is fit, always go for concurrent chemoradiation followed by immunotherapy or follow-up, whatever is depending on the patient. So the data again comes from real world. I'm a big fan of real world data because nowadays we are coming up with publications on real world, because trial data is always trial that select supremely fit patients to go on a trial, and that data will always be superior by around 20% to what you see in the real world. So you can see here very clearly that the concurrent chemoradiation has superior outcomes compared to those patients who got just RT or radiation chemo alone. Now, what is the, because the outcomes traditionally were poor, there were options. People try to do consolidation after chemoradiation with a switch agent, docetaxel, or give it etoposide cisplatin, carbo, or additional radiation, or gefitinib. We do have data on ADAURA that if you resect these patients and they are EGFR positive, you can give osimertinib. But whether that really translates into those patients who get chemoradiation is not very clear. So most of these trials which looked at consolidation did not show much of an advantage. So the post consolidation therapy did not show advantage, whether it's chemo or radiation at any point of time. Now, what happens when we use carbo is the fact that there's always a fear of radiation pneumonitis, and that is something we have to be very worried about. And in this patient, there was this issue, and it's a tapering dose of steroids. Now, this brings an important question. If you develop radiation pneumonitis, do you completely avoid immunotherapy in this subset of patients? Or if the patient improves, what do you do? In a real world setting, I've seen a patient similarly who comes to me from outside after getting chemoradiation, having pneumonitis for 2 to 3 months, and progresses after 2 years. And for that patient, I've used immunotherapy and patients are all gone to complete remission. So this is a tricky thing. It depends on the clinical scenario. Guidelines say the patient has improved within 7 to 6 weeks. You could consider keeping it at a high risk. So this is important that you have to discuss when you're taking your patients for treatment. Now, coming to the Pacific study, it was a phase 3 randomized double-blind placebo-controlled study, multinational, multicentric study in which patients with stage 3 locally advanced unresectable non-small cell lung cancer who had not progressed post a platinum-based concurrent chemoradiation with a good performance, expected life expectancy of more than 12 weeks. And they were randomized post chemoradiation between 1 to 42 days. So that is an important thing. So a lot of times we are confused about when should we bring in the chemoradiation? What's the time duration? The trial, I had spoken to the people who did the trial. They said that they would enroll patients even without doing a scan if the patient was X-ray was fine. So that is why the randomization is 1 to 42 days. So it depended from patient to patient. Patients who had no overt disease progression, no disease or symptoms or were fine, they actually were randomizing very fast. How many patients underwent randomization, and that duration is not very clear on the study. So these patients are randomized into a 10 mg per kg durvalumab every 2 weeks for up to 1 year in a 2:1 randomization with stratification based on age, sex, and smoking history. And the other arm received placebo for around 12 months. The primary endpoint was PFS and OS, and the key secondary endpoints were objective response rate, duration of response, safety, and safety. Now, if you look at the baseline characteristics of the study, all patients received at least 2 cycles of concurrent chemoradiation at some point of time and had received chemotherapy. And like I said before, 26% of these patients had received some sort of induction chemotherapy prior to starting chemoradiation. Now, this is the important thing that you see is that if you look at the updated OAS of 5 years, what you see is that durvalumab versus your placebo, the 5-year OS is around 42% versus 33%. So which is dramatically improved, which is much better than what you see upfront with around 12% to 15%. So this is what you would see when you add immunotherapy to these patients. Now, if you look at the progression-free survival, again, at 5 years, it is 33% versus 19%, and shows you the benefit of adding immunotherapy to these subset of patients. And remind you, these were irrespective of the PD-L1 status. Now, if you look at this this plot, what you'd understand is that in most of the patients, the benefit of adding immunotherapy was there, irrespective of the squamous, adeno, histology, whether there's a partial response, complete response, the PD-L1 more than 25%, less than 25%, or even unknown. The only area where you can see that it causes the margin of 1 is when the EGFR is positive. So that I think is important. That thing that when we evaluate these patients for treatment, it's important to check the baseline all-cause EGFR, because I may be hesitant to use an expensive agent in these patients, like immunotherapy, when I'm using immunotherapy in these patients. Now, if you look at the updated OS and PFS in the pre-specified subgroups, again, you can clearly see that addition of immunotherapy was better. So there isn't much to differentiate between the role of immunotherapy and the shows you that immunotherapy showed a better outcomes in terms of OS and PFS in the pre-specified subgroups of these patients. Now, what are the when would you act? This is what everybody asks, and we always discuss in all the meetings is post-chemo radiation, when should we reassess the patient? Should we reassess? If at all we reassess, should we do a CT scan? Should we do a PET scan? What about the pneumonitis? What about the false positivity that you would see? And what's the best time to start durvalumab, considering the treatment is expensive and can have potential toxicities of pneumonitis? Now, this patient improves, and after an 82 days of chemo radiation gets onto durvalumab. Now, after 3 months of treatment, what this patient sees, patient doesn't develop active disease toxicities, and there's a good response to treatment with a reduction of size and FDG activity of the lung lesion. Shows that there's a response to therapy. Now, the question of when to start durvalumab in Indian patients and in the real world is always controversial. There was a study from France which looked at real-world settings of patients, including on 590 patients, and they looked at patients who were unresectable stage 3 without any prior treatment going into a clinical trial. And after 2 doses of at least platinum-based doublet with totally chemo with radiation, patients had a good performance status. They initiated the durvalumab within 42 days of the end of radiation. So what they would see is around 360 patients out of 2019, they could evaluate out of the 570 patients, 360 patients. What you would see is CRs of around 10%, PRs of 20%, stable disease of around 43%, and progression of around 21%. So, which again shows you compared to the placebo arm, the addition of durvalumab has an improved objective responsivity, which is statistically significant. So, yes, I do agree that because we're using expensive therapy, we could wait for around 6 weeks, that is around 42 days. I would, in my practice, the patient is fit, stable, do a reimaging of the end of 5 weeks or 6 weeks to see if there's any gross pneumonitis disease progression. If there's gross disease progression, then something I wouldn't do. Otherwise, you're always worried about inflammation and all those, which we should discuss with the radiologist and in the tumor board to make a final plan. So if you look at this study, they have around 40 patients, 40% of the patients were initiated on durvalumab after 42 days post-chemo radiation. And this is again quite similar to what you saw in the specific study in which they had done the same. And this patient continues to get immunotherapy and has an improved survival. So what we conclude here is the fact that, one, in my mind, the important thing is that you have to be taking a tumor board discussion in all these patients. You have to be clear in your thought process when you start treatment for these patients. I would definitely, for all these patients, do an all-cause EGFR to be sure of the mutation that is there. I would consider doing a PD-L1 for these patients if it is feasible, which I think is important. And primarily decide whether this patient is for surgery or not surgery. Whether he's fit for surgery, the type of surgery has to be pneumectomy or lobectomy, and mediastinal staging, whether it is overt N2 disease, N3 disease, whether it is bulky N2, N3 disease, whether it's extracapsular extension is there. So all these things will tell me whether he's for surgery at any point in time. If he's not for surgery, then it would be for chemoradiation. If he's borderline for surgery, then that has to be discussed for giving induction chemo with nivolumab or not has to be discussed. Otherwise, if it's a chemo radiation based on the performance status and the characteristics discussed, I would give chemo radiation for these patients. And again, the type of chemotherapy, for the sake of convenience, paclitaxel is shown to be non-inferior to etoposide cisplatin because of the toxicities with paclitaxel are much lesser than giving etoposide cisplatin therapy. And post this thing, I would wait or talk to the patient and wait for a period of 4 to 5 weeks before I reimage, and then plan for durvalumab at any point of time in these patients, hoping to extend the survival and benefit in our Indian patients as well. So if you look at the guidelines, which is a combination of an NCCN and there's an expert consensus from India showing that this important thing is that N2 has to be deemed resectable. So
Dr. Ashwin requests you to conclude in the next
about it, just to make sure that yes, consolidation is a standard of way to go right now. You have to be sure of your treatment plan, and I would say that for those patients who are stage 3 who do not have a targeted mutation, immunotherapy is the way to go forward after you give concurrent chemoradiation, do not have disease progression. Thank you.
Thank you, Dr. Ashwin. That was a masterclass in stage 3 non-small cell lung cancer. I fully agree that PD-L1 as well as EGFR should be done because in the responses in PD-L1 negative as well as wherever EGFR positivity is there, the responses.
It's a warm invite, and thank you, Rosh, for providing me the talk. Geetika, can you share my slides, please? So I'll be talking about the management of NSCLC with the respect to the atezolizumab now and what is next. Next slide, please. So there is a busy treatment slide of chemotherapy and immunotherapy or anti-angiogenic therapy in the first line treatment from the standard of care, which is chemotherapy platinum doublets. So we have progressed and giving chemotherapy platinum doublets with anti-VEGF therapy or cancer immunotherapy doublet in the first line treatment option. It has been a standard of care. Ever since the 2018 Nobel laureates James P. Allison and Tasuku Honjo found a seminal discovery by these two Nobel laureates constituted a landmark fight against cancer, where they found that there are different strategies where we can inhibit the brakes on the immune system. However, on second line treatment, repeating a cancer immunotherapy is not an option. Next slide, please. So as we can see, the landscape of management of NSCLC included the FDA approval of immunotherapy in 2016 in second line. And now, as based on the studies like IMpower 150, 130, and 110, they have become the management of first-line chemotherapy in those patients who have PD-L1 expression. So atezolizumab in first-line metastatic non-small cell lung cancer is now a reality, and the IMpower 110 is a study which looked at which looked at atezo monotherapy. Is it better than giving a chemotherapy doublet in PD-L1 selected but chemotherapy naive patients? IM 130 looked at nab-paclitaxel and carboplatin, again a double platinum standard therapy, which is a steroid-sparing chemotherapy regime. Is it better as a combination partner to use atezo or not? And IMpower 150, where atezo added to the standard of care bevacizumab with paclitaxel, does it give any clinical benefit, or is there improved benefit if beva is replaced by atezo altogether? So we shall see in the next few slides. So IMpower 110 looks at atezo monotherapy in the standard doses of 1200 milligram 3 weekly for 4 to 6 cycles, along with non-squamous NSCLC in advanced stage getting carboplatin or cisplatinum with pemetrexate as its partner, and in squamous cell NSCLC, carboplatin or cisplatinum with gemcitabine was used in the standard dosages. And then this was given maintenance with pemetrexate or even or a best supportive care in squamous cell, and this was used up to progressive disease or a loss of clinical benefit. And they were randomized in a ratio 1:1. The patients who were selected were all with non-stage 4 non-small cell lung cancer, either squamous or non-squamous. They were chemotherapy naive, they were EGFR ALK negative, and they were stratified as per sex, ECOG PS001, as per histology, squamous and non-squamous, and the level of PD-L1 expression. The primary endpoints were overall survival, and the secondary endpoint was PFS, investigator assessed, overall response rate, and duration of response. Next slide, please. So the primary endpoint of OS in the patients who had tumor cell 3 or immune cell 3 expression, meaning that those patients where the tissues were by Ventana SP142 found to have more than 50% expression on the tumor cells or on the immune cells more than 10% expression. The median overall survival was 20.2 months versus 13.1 months for chemotherapy, thereby giving an overall improved OS of 7.1 months. Next, please, with the HR of 0.59, meaning more than 41% patients would be alive in the atezo arm. When we looked at PFS, there was definitely an improvement of PFS with a meaningful clinical benefit, 8.2 months versus 5 months. Next, please. And when we look at the population of the updated analysis of TC3 or IC3 in the wild population, the overall response rate was improved with atezo versus chemotherapy, as we can see in the cartoon here. Next, please. So whether we use SP142, which looked at the tumor cells and the immune cells, or we look at 22C3 or SP263 by Ventana, the methods were comparable. Next slide, please. So the overall adverse events occurred in 92% of the atezo arm and 95% of the chemotherapy arm, but the grade 3 to 4, which was significant adverse effects, were only in 33.9% in the atezo arm and 53% in the chemo-related arm. The grade 5 adverse events were about 4.2%, which were equal in both. The updated safety analysis was consistent with the primary analysis, and no new safety signals were observed on a longer follow-up. Next, please. The adverse events, as can be seen commonly with immunotherapy, were mainly hypothyroidism or skin rashes or an increase in ALT/AST, and the chemotherapy adverse effects were manageable. The updated safety analysis was consistent with the primary analysis. Next, please. So in summary, the IM power of 110 is a positive study that showed that there was a significant and meaningful improvement in OS in the TC3, IC3 wild population, which was selected for having PD-L1 positivity more than 50% or the immune cells more than 10% by SP142 versus chemotherapy arm. And since this, there was also a clinical benefit in the progression-free survival, overall response rate, and the duration of response when we compared this with chemotherapy. So definitely this became now a new standard therapy, standard of line, and broke the age-old double platinum being the standard of care for advanced NSCLC. The safety profile was consistent with prior observations, and no new danger signals were identified. Next, please. The next study, which talks about the phase 3 study of carboplatin with nab-paclitaxel, steroid-sparing chemotherapy, with or without atezolizumab in first-line advanced non-small cell, non-squamous NSCLC. So the patients were stage 4 NSCLC, mainly non-squamous, mainly adenocarcinomas or large cell, chemotherapy naive in performance status 0 and 1, and were stratified according to sex, PD-L1 expression, and liver mets. They were randomized in a 2:1 ratio, with the arm A having atezolizumab or Tecentriq with carboplatin and nab-paclitaxel given for 4 to 6 cycles in the standard dosing. And then maintenance with atezo was followed up till loss of clinical benefit or progressive disease. In the second arm, carboplatin and nab-paclitaxel for 4 to 6 cycles with switch maintenance to pemetrexate was permitted and till progression. Next, please. So the design looked at the endpoint of investigator-assisted PFS and secondary endpoint of overall survival and intent to treat arm. Next slide, please. So we know the rationale of giving chemotherapy with immunotherapy, and we know that the tumor antigens would be, next please, would be or released, and the cancer antigens would be presented. There would be priming, trafficking of T cells, and a better immune response would be, immunotherapy effect would be there when we combine with immunotherapy, and the cancer cell kill would be better. Next, please. Next slide, please. So, as I said, the rationale was nab-paclitaxel, we know, is a solvent-free is a formulation, which doesn't come with Cremaphore as used to come in the traditional paclitaxel earlier. So steroids can be avoided, which have a potential immunosuppressive action and may reduce the efficacy of immunotherapy. Hence, this combination is a desired combination for combining chemotherapy with immunotherapy. Next slide, please. And as we can see, the investigator-assisted PFS showed definitely at 6 months and 12 months a definite advantage of combining atezo with carboplatin and nab-paclitaxel with a 12-month advantage of 29% versus 14.1%, or on a median and this median follow-up was 18.5 to 19 months. The HR ratio was 0.64. Next, please. And since the PFS benefit was observed across all subgroups, that means across whether for sex, age, performance status, smoker, non-smoker, or liver mets, they were all PDL1, all 3 arms with a TC3, TC1 or 2, or even when they were negative, the benefit was observed that atezo is better. Next slide, please. Next slide, please. Yeah. So the OS was also significantly improved with the addition of atezo to carboplatin and nab-paclitaxel in the intent to treat wild-type population, and this benefit was observed even at 2 years. Next slide, please. This was again seen, the clinical relevant subgroups, all subgroups, the benefit was noticed across all subgroups that atezo was better than giving the chemotherapy alone. Next, please. So the overall response rate and duration of response would definitely improve when we added atezolizumab to chemotherapy in the intent to treat population wild type. Next, please. So in summary, IMpower met its co-primary PFS and OS endpoints and demonstrated that it is statistically significant and a clinically meaningful benefit, 4.7 months of OS and 1.5 months of PFS in the atezo plus chemotherapy arm was there when compared with chemotherapy alone. And the benefits were across all subgroups, especially across all PDL1 subgroups. Atezo plus chemotherapy has a high safety profile as shown in the previous study as well. So IMpower 130 supports atezo plus chemotherapy as a treatment option for advanced adenocarcinoma or large cell non-squamous NSCLC. Next, please. Now we'll go to the third study, IMpower 150, which again had a group of non-squamous NSCLC, which was a phase 3 trial of atezo plus chemotherapy and bevacizumab in first-line advanced NSCLC. The patient population was stage 4 NSCLC or recurrent metastatic non-squamous NSCLC who were chemotherapy naive and who had adequate tumor with DNA available for biomarker testing with any PDL1 by IHC status. They were stratified by sex, PDL1 expression, and liver mets. Total of 1,202 patients were randomized in 3 arms in a 1:1:1 ratio. The first arm contained atezo with chemotherapy of paclitaxel or carboplatin and for 4 to 6 cycles and a maintenance therapy with atezo alone. The second arm had atezo, carboplatin, paclitaxel with bevacizumab, which was at that time the standard of care. followed by atezo and bev maintenance. And the arm C looked at carboplatin and paclitaxel with bevacizumab, followed by bev maintenance if there was a benefit. They were treated till progressive disease or loss of clinical benefit was there. The co-endpoints were PFS in intent to treat wild population and OS in the same group. Next, please. So the patients were well matched for the baseline characteristics. 14% of these patients had liver mets at baseline, and they were stratified for this. 10% of patients had EGFR mutations and were balanced across all three arms. And there was a 50 to 50% split of PD-L1 positive and negative patient across all arms. And there were about 402, 400, and 400 patients in the three arms. Next slide, please. So as we can see, the curves separate, and there was a OS benefit with the addition of atezo in arm B versus arm C. Arm B is the one which contained atezo, bevacizumab with chemotherapy. And arm C contained bevacizumab with chemotherapy alone. So here we can know that definitely at a median overall survival of 19.5 months in the combination arm with 4 agents versus 14.7 months was with the HR ratio of 0.08 was significant. Next, please. The improvement in median OS of 4.5 months became clinically meaningful in this group. Next slide, please. So the overall response rate and duration of response were also improved with the median duration of arm in the 4-drug regime, arm B, of 11.5 versus 6 months, and a high proportion of patients responded with treatment with atezo, bev, plus the chemotherapy arm. Next slide, please. So for all groups of PD-L1 with a high, intermediate, the ABCP arm versus the BCP arm, which is arm B versus C, definitely had an advantage and derived a benefit. The highest benefit was with those patients which had a very high PD-L1 expression, had the maximal benefit, as seen with the median OS of 30 months in this ABCP group versus 15 months. Next slide, please. The OS benefit was, as I said, across all PD-L1 subgroups, whether TC1, 2, 3, or even in those who were PD-L1 negative. Next slide, please. Although the patients who were EGFR mutated, even after EGFR TKIs, if they had progressed, they did benefit by adding atezo. And they were uniformly distributed across all three groups in the intent to treat population in this study. So when there was an EGFR mutation or an ALK rearrangement, as is seen in 160 patients, EGFR mutation in 124, and sensitizing EGFR mutations in prior TKI therapy in 78 were there. Next slide, please. So the PFS advantage was observed not only for arm B, arm C in patients with EGFR mutations, and the PFS curve starts separating around 6 months, which shows that this has a benefit even in this subpopulation. Next slide, please. So as you can see, the hazard ratio of 0.60 for the median overall survival. And in arm A versus arm C, they were almost the same. So no benefit was observed between arm A and arm C, but arm B, where the bevacizumab, where atezolizumab was added to the paclitaxel with bev arm, definitely there was a benefit. Next slide, please. So the OS benefit in patients with EGFR mutations with prior TKI therapy is a significant achievement, and there was a continued separation of curves with the OS benefit with the addition of atezo to bevacizumab plus chemotherapy in the arm B. Next slide, please. Whereas no benefit was there in the other arms. The overall response rate and duration of response have also been shown to be benefited, where we can see the median duration of response was 11.1 months in the ABCP group, which is arm B, versus the bevacizumab plus CP, which is arm C, where it was 4.7 months only. So the efficacy in other key subgroups, as we came to know, there were around 14% patients with liver metastasis. And a PFS advantage in arm B, where the ABCP group was maintained all around as 58%, 34%, and 23% at 6, 12, and 6 months, 12 months, and 18 months. And in arm C, this was definitely inferior to the ABCP arm. So patients with liver metastasis have a clinically meaningful survival benefit with the IMpower 150 regime, despite liver metastasis being a negative prognostic factor in this very dynamic advanced NSCLC disease. So, as we have said earlier, the median overall survival in this particular subgroup was 13.2 months versus 9 months. Next, please. And the addition of Bev to atezo plus chemotherapy improved overall response rate and duration of response, which we have seen earlier. But when we talk about this particular subgroup of liver metastasis, the median duration of response was for 10.7 months versus 4.6 months. It is nearly doubled. So this is a good combination to give in those patients who have nominal FT but have liver metastasis in non-squamous NSCLC advanced. Next, please. Even in patients with bulky disease, next slide, please, with a high burden of disease, they had a better survival. Next, please. So when we define patients with a high burden of disease, where we use atezo with bevacizumab and chemotherapy, the median overall survival was 15.5 versus 10.7 months. Where is the difference was only marginal in the low disease burden. And when the number of sites were measured, again, the atezo plus bev and chemotherapy showed a 17.6 months versus 12.5 months overall survival, which was pretty significant compared to the low burden disease sites. So the clinical benefit of adding atezo to the bevacizumab and chemotherapy arm was observed in patients with bulky disease, regardless of the approach to define bulky disease, whether by number of METs or by the RACES criteria. The benefit was definitely pronounced in this high disease burden subgroup. These data support the use of atezo with bev in chemotherapy as a first-line option for patients with high disease burden. And atezo plus bev was well tolerated with an acceptable safety profile, although there was a higher proportion of treatment-related grade 3 to grade 5 adverse events. The adverse events of special interest in the bev and atezo arm in arm B was expected because of the additive effects of 2 plus 2, 4 total drugs, and treatment would have to be individualized, but there were no new safety signals. Next, please. So in summary, IMpower 110 shows that atezo monotherapy in high PD-L1 expression for both squamous and non-squamous histology in advanced NSCLC can be used as a first-line therapy. IMpower 130 shows that atezo plus chemotherapy, which is steroid-sparing nab-paclitaxel and carboplatin in non-squamous histology, is a potential regime, and PDL even expression below 1% or up to 50%, or all patients did well. And even this is an option in patients who have renal dysfunction and even uncontrolled diabetes, where we are not adding the burden of steroid-related worsening of diabetes, which is very common in the patient subgroup we see in our clinic. IMpower 150 showed that atezo plus bev with chemotherapy, paclitaxel and carboplatin in non-squamous histology, PD-L1 all-comers, there's a significant benefit specifically in patients who have progressed in TKIs, which was a surprising finding, with liver metastasis and bulky disease, whichever way you defined it. Next slide, please. So a disease-free survival benefit was seen in all randomized stage 2 to 3A population also, and a statistically significant 21% reduction of risk of disease recurrence was there when we compared atezo with best supportive care to a median disease-free survival of 42 versus 35 months. Next one. Next, please. Thank you. So I have really finished, and these are the studies which show us that atezo is a significant new addition to the busy slide of immunotherapy along with chemotherapy or doublets of immunotherapy in the advanced NSCLC setting.
Thank you, Dr. Chaudhary. That was a lovely presentation about atezolizumab in the spectrum of a non-small cell lung cancer. I think one part is that probably PD-L1 less than 50, there is a in squamous cell carcinoma. It is difficult to, it is not being given. And I have been very difficult to give ABCP regime to all to my patient. Even
Yes, sir.
high burden, very difficult treatment. Anyway,
Yes, sir.
it was wonderful presentation, and thank you very much. And now we proceed on to the next presentation, which will be by Dr. Mukesh Bansal. He is a consultant medical oncologist from my neighbor hospital, that is Alchemist Hospital, and he'll be talking on how to treat extensive stage small cell lung cancer with durvalumab, a real life experience. Dr. Mukesh, please.
Good evening, everyone. Thank you, sir. Thank you, organizers, for giving me this opportunity. Can someone play the slide? Yes. So the topic given to me is how I treat extensive stage small cell lung cancer with durvalumab, a real world experience. Next. So this is a case of Mr. X, a 35-year-old gentleman who presented in June 21. He complained of change in voice, which slowly progressed to aphonia. There were no comorbidities. History of smoking is there. He visited his ENT physician, who diagnosed him with vocal cord palsy. Underwent CT scans, workup, brain, head and neck, and chest. Next. Next slide. So the CT showed a small, mild enhancing soft tissue nodule with surrounding fibrosis in left apical segment. There were multiple and large conglomeratic necrotic lymph nodes in hilar, paratracheal, and paraesophageal lesions. Aortic pulmonary ward forming nodal mass compressing left pulmonary artery. Next. Based on these reports, he was started on ATP, which actually I doubt without any sputum cytology or AFP. But in this case, he was started on ATT. His condition worsened. He had an episode of seizure in September, started on anti-epileptic drugs, followed up with an MRI brain scan. Next. So the MRI brain shows a 2 into 1.9 centimeter size marginally enhancing intraaxial lesion, right temporal lobe with mild surrounding edema. There were multiple subcentimetric size lesions in bilateral temporal and left frontal, parietal, occipital lobe. Next. He underwent a HRCT scan again. There was a occupying lesion in upper lobe, left lung with mediastinal extension and encasement of left pulmonary artery, mediastinal lymph node, and consolidation in left upper lobe. Next. So finally, he underwent a PET scan for the staging. So these are the photographs of the PET scan showing the lesion in the left lung upper lobe. Next, with mediastinal lymphadenopathy. Next. So on histopathology, it was found to be small cell carcinoma. His PD-L1 tumor proportionate score is 3 to 4%. Next. So final diagnosis is small cell lung cancer, extensive stage, because he had a brain met at the presentation also. Next. So what should be the ideal next step? Should it be a radiation followed by systemic therapy? Should it be chemotherapy alone, or should chemotherapy should be combined with immunotherapy in this case? Next. So this is a article published, treatment of brain mets in small cell lung cancer, decision making amongst a multidisciplinary panel of European experts. So the key conclusions of this study, which are well accepted by NCCN and ESMO guidelines also, that in asymptomatic patients, we did not give radiation. We can proceed with chemotherapy plus minus immunotherapy as the first line recommended treatment. In asymptomatic patients with limited volume of brain mets, a higher preference for chemotherapy plus minus immunotherapy is still there. But in symptomatic brain met patients, first radiation whole brain RT should be given, which should be followed by chemotherapy or systemic therapy. In symptomatic patients with limited extent of brain mets, we may choose stereotactic radiation as an alternative to whole brain radiation, because as we know that whole brain radiation has its own side effects, especially in a young patient like our case of 35-year-old. we may want to avoid whole brain radiation and choose stereotactic radiation. Next. Even the NCCN guidelines, the latest version 2023, if we see, so extensive stage disease without symptomatic brain mets, if the good performance status is good, then combination systemic therapy, which includes chemotherapy plus immunotherapy, is recommended. In extensive stage with localizing symptomatic sites like superior vena cava syndrome, bone mets, lobar obstruction, spinal cord compression, a radiation can be given before the chemotherapy to initially give symptomatic relief. With extensive stage with brain met patient, in asymptomatic patient, we may proceed directly to systemic therapy. In symptomatic patients, brain radiation is given before systemic therapy. Next. These are the various chemotherapy studies done in extensive stage small cell lung cancer, which showing the efficacy of the standard regime used, EP regime, etoposide and platinum. Next. So this patient was started on chemotherapy, etoposide plus cisplatin. Radiation therapy was given before chemotherapy, 30 gray 10 fractions to whole brain with hippocampal sparing, followed by 9 gray 3 fractions to gross region. Next. So again, showing the NCCN guidelines, etoposide, carboplatin, or cisplatin plus atezolizumab, 1200 mg every 3 weeks, 4 cycles, followed by maintenance atezolizumab is the category 1 recommendation in extensive stage small cell lung cancer, first line therapy. Next. Previous slide. Previous, yes. Other than this, the recommended guidelines, the preferred regime also includes etoposide, platinum plus durvalumab, 1500 mg every 3 weeks, 4 cycles, followed by durvalumab. So we can either combine atezolizumab with etoposide carboplatin or combine durvalumab with etoposide carboplatin. Next. Next. So after cycle 3 of chemotherapy, durvalumab was added in this patient, 1500 mg every month. Next. This is a basic rationale of combining immune checkpoint inhibitors with chemotherapy in small cell lung cancer. It plays a role in eliciting an anti-cancer response by modulating the patient's immune response to the tumor. High mutational burden of small cell lung cancer may allow this tumor to be susceptible to immunotherapy. The timing of immunotherapy in relation to other therapies, in particular chemotherapy, is critical to allowing disease control and the development of an immune response. So PD-1, PD-L1 inhibitors, as this diagram shows, work because the tumor cells have PD-L1 ligand, which inhibits the PD-1 receptor on the tumor. Cancer cells has PD-L1 ligand, which inhibits the PD-1 receptor on the tumor cell. So these agents inhibit the PD-L1 or PD-1 and thereby increase the immunity. Next. So Caspian is the first and only approved IO regime in extensive stage small cell lung cancer to allow up to 6 cycles of EP in the control arm and use of cisplatin. Because in the study of atezolizumab, there were mostly 4 cycles of EP were given, and that too carboplatin was combined with etoposide. Cisplatin was not used. So in durvalumab study of Caspian, either cisplatin or carboplatin was allowed, and up to 6 cycles were allowed. So ECOG performance status 0-1, life expectancy more than 12 weeks, at least 1 target lesion were cyst. Patients were stratified by cisplatin or carboplatin use. Imfinzi, that is durvalumab plus EP versus EP alone were the arms. So primary endpoint was overall survival, and the endpoints were progression-free survival, overall survival at 18 months, health-related quality of life, overall response rate, and PFS. Caspian allowed for investigators' choice of platinum-based chemotherapy.
Patients with asymptomatic or treated brain met
Were there. The control arm allowed for up to 6 cycles of chemotherapy and PCI, that is prophylactic cranial radiation,
radiation
as per investigators'
discretion.
So if we compare
IM power 133 versus Caspian study,
no biomarkers were required. Untreated
brain mets were included in the IM power study, which were included in the Caspian study. PCI allowed in control arm. There were around 10% of patients in IM power. PCI allowed in experimental arm. These patients were included in IM power but excluded in Caspian.
Up to 6 cycles of chemotherapy in control arm was allowed in Caspian. Cisplatin was allowed in Caspian, which was excluded, not allowed in IM power study. Carboplatin is allowed in both of the trials. So
Caspian study inclusion criteria is reflective of real-world clinical practice
because we sometimes
choose cisplatin in combination with etoposide or
carboplatin.
It's not that we put all our patients on etoposide carboplatin only. So Caspian study allowed the use of cisplatin.
Most of our patients
get 6 cycles of chemotherapy, which is the real world practice, which was followed in Caspian but was not allowed in IM power. Next.
So durvalumab
1500 mg plus platinum etoposide 3 weekly for 4 cycles in the
initial treatment phase, followed by durvalumab
1500 mg 4 weekly until progression as maintenance. This is again the same thing. Cisplatin and carbo was allowed. OS was the final primary endpoint. Control arm, 6 arms could be next. So this is the progression-free survival. Median progression-free survival in the durvalumab plus EP arm is 5.1 months. In the EP arm, 5.4 months.
So PFS was not formally
tested statistical significance.
Next. So majority of
Patients who are progression-free at 1 year remain progression-free even after 2 years in the
durvalumab plus EP
arm.
Next.
Durvalumab plus EP is the first and only approved IO to demonstrate a statistically significant and sustained improvement in overall survival versus etoposide platinum at 12, 24, and 36 months. So median overall survival in durvalumab plus EP was 12.9 months compared to 10.5 months in the EP arm. So there is benefit of around 2.5 months.
Hazard ratio is 0.71.
P-value is significant. 3 times more patients were alive in durvalumab plus EP versus EP arms
at 36 months. So this trial showed the long-term survival benefit of adding durvalumab to the EP arm. Next. At 3-year overall survival benefit consistently favored durvalumab plus EP across 3 specified subgroups that are reflective of clinical practice. So there were 537 patients. In all patients, we compare the benefit is towards adding durvalumab. In both the carboplatin subarm and cisplatin arm, there was benefit in the durvalumab arm. In age less than 65, more than 65, males, females, by performance status 0 and 1, by smoking status, by CNS or brain met, by race, by reason. So almost every subgroup favored durvalumab plus EP 3-year overall survival. Next. So overall objective response rate was 67.9% in durvalumab arm, but 58% of patients in the EP arm. Median duration of response is almost similar, 5.1 months in both the arms. Next. Durvalumab plus EP consistently improved overall survival versus EP regardless of presence of baseline brain mets.
So as we have seen in both the subgroup with brain mets and without brain mets, there was benefit by adding durvalumab. Median overall survival in brain met patients was 11.7 months in the durvalumab arm versus 8.8 months in the EP arm. Without brain mets, it increased to 12.9 months in the durvalumab arm versus 10.5 months in the EP arm, giving a benefit of around 2.5 months. Overall survival and PFS benefit with first-line durvalumab plus EP are maintained irrespective of the presence of brain mets, further supporting its standard of care use. Next. So follow PET scan, which was done in January 2022 after radiation, chemotherapy, and combination immunotherapy. Next. Next slide. So these are the photographs. As you have, we can see that there is a response in the primary lesion, in the mediastinal lymph node, in the left lung upper lobe lesion. Next. April 2022, after completion of initial chemotherapy, immunotherapy maintenance, durvalumab maintenance was continued. Next. There is further decrease in size of photopenic area in right parieto-occipital region of the brain, decrease in metabolically inactive minimal soft tissue thickening in AP window. No metabolically active disease elsewhere is present. So there is near complete response in the PET scan of April 2022. Next slide. We can confer that Imfinzi is the only IO with clinical trial data supporting a 4-weekly maintenance dose administration schedule for extensive stage small cell lung cancer patients. Maintenance is easier as compared to the other drug, as 4-weekly maintenance can be given. Next. Imfinzi plus EP is more cost-effective versus EP alone, as well as atezolizumab plus EP for the treatment of extensive stage small cell lung cancer patients. So they have compared the cost, which actually says that Imfinzi is little bit cheaper than Tecentriq. Next. So to conclude, durvalumab plus EP can be the new standard of care in the first-line treatment of extensive stage. It has shown sustained improvement in overall survival compared with a robust control arm that is reflective of a real-world scenario by allowing up to 6 cycles of EP and use of PCI as well as use of cisplatin or carboplatin. Benefit was observed in across all subgroups, including brain metastasis patients. More than 17% patients on durvalumab plus EP arm are surviving even after 3 years, showing prolonged survival benefit. Imfinzi plus EP provided a high response rate and demonstrated ongoing response at 2 years in 3x more patients than EP arm. It offers convenient once-monthly dosing regime in the maintenance phase. Safety findings were remained consistent with the known safety profile of durvalumab plus EP. Thank you.
Thank you, Dr. Mukesh. That was a lovely presentation. I think both this atezolizumab as well as durvalumab are equally effective. We will wait for long-term results of both, but I think both are equally good. And durvalumab has shown, I mean, we have now something to give in small cell lung cancer. Otherwise, there was not much to give. Thank you very much. And now we proceed on to the next talk. And we finish the lung cancer. Now we go to lower abdomen cancer. In this, first will be Dr. Rahul Sood, friend, a senior consultant, medical oncology in Command Hospital, Chandimandir. He's coming from Bangalore to this place. Dr. Rahul, please, he'll be talking on atezolizumab in unresectable and metastatic SCC. Dr. Rahul, please.
Thank you very much, sir. And it's a great honor and privilege that you gave me this opportunity. And it's a privilege to be on this platform. You've been a wonderful teacher, and whatever we've learned so far in oncology, a great proportion goes to you, sir. So always indebted to you, sir. So if the organizers can let me share my screen, I'll do that.
Sure, please.
Right. So I'll be talking about the hepatocellular carcinoma. And like Sir mentioned, we have moved from lung now to HCC. And whenever we went to HCC, I hope my slides are visible.
Yes, they're visible.
Yeah. So whenever we talked about hepatocellular carcinoma, the first thing that we always used to think is why HCC and why don't we have a good treatment for hepatocellular carcinoma? And for a very long time, this question was never answered. So today I'll be discussing regarding the role of atezolizumab plus bevacizumab as first line in unresectable HCC. So my slides have been given to me by Roche, and I'm indebted to them because such quality slides I can never ever make in my life. So the liver cancer global incidence mortality is extremely high, though it may be the sixth most cancer overall, but it is the third leading cause of global cancer mortality, accounting to 8.3% of all cancer deaths. So as you can see, the males are the ones who predominate as compared to the females, alcohol being one of the commonest cause which is there. But remember that more than 75 cases of liver cancer or the HCC occur in countries like ours, which are less developed regions of the world. Well, the causes for that is we know it is the presence of the viruses, the consumption of alcohol, presence of NASH, and aflatoxins, which are very, very important. Men are threefold higher risk for developing liver cancer, and that is why we should be pertinent. So amongst the liver cancer, the HCC accounts to 90%. However, cholangiocarcinoma is the predominant amongst the 10% of the others. We also have seen that cholangiocarcinomas over a time period, especially in the belts of the gangetic belts, have also increased along with the gallbladder cancers. Angiosarcoma and hepatoblastomas are other causes. We'll be harping more on the HCC today. So this is how the HCC evolves. The presence of cirrhosis is what triggers HCC. So HCC, the chronic hepatitis, which will lead to cirrhosis, and chronic hepatitis can occur due to viruses, alcohol, NASH, and aflatoxin, like I mentioned, leads to early HCC, which it may be localized to a particular lobe of the liver, and then advanced HCC, where you have multiple lesions in the liver and maybe liver outside. Remember, 10 to 20% of HCC do not also arise from cirrhosis. So cirrhosis may not just be the underlying cause. So in such cases, the biopsy becomes very, very pertinent as per the American as well as the European criteria. So where are we? And this is what we are mainly interested. That is the Indian scenario. Remember, 35,000 new cases of liver cancers were detected in 2020. We are now in 2023. The numbers would have definitely increased and not reduced. Liver cancer was the 8th most common cause of cancer, which was there. And remember, see the 5-year prevalence rate of 2.8%, highest grave unmet need for the disease treatment, which is there. So what do we do about it? We still have the unmet need in India. That is, majority of the patients are detected in the advanced stages. You see our GI surgeons or the oncosurgeons just telling us that the patient is not fit for resection, not fit for liver transplant, probably also not fit for any local therapy because of that. And therefore, the patient lands up with the medical oncologist. A 5-year survival rate of 2.3% in India, which shows a grim, poor picture. The tyrosine kinase inhibitors, which came up in a big way, we had the SHARP trial. Then, however, what we found out is we were never able to give the full dose of sorafenib to any of our patients. They never tolerated those things, and therefore the results were dismal. If I say the overall survival was 1 year, I'm really stretching it. The progression-free survival and the quality of life with TKIs are also poor. So there is a lack of better treatment options which are there. So apart from a superior clinical outcome and similar safety profile, I think newer drugs were required, and that is what was the need of the hour. So as you can see, after sorafenib, there was nothing till 2016, and then came lenvatinib and the immunotherapy bevacizumab combination, and the various other second-line therapies which we go for when the patient progresses on the first line. So what is the rationale of combining immunotherapy and anti-VEGF? Well, I think all my speakers before me have literally explained all these things. So my slides may be a repetition. What is important to understand is whenever you combine whenever you do this, you are basically creating new antigens which are there. These new antigens will cause priming and activation, and new activation will cause trafficking of the T cells to the tumors and the infiltration of the T cells into the tumor, resulting in the tumor death. What is important in HCC is that the tumor infiltrating T cells are found in more than 50% of HCC patients. So we can utilize this power of the T cells, the tumor infiltrating T cells in the therapeutics that are there. Also, the HCC may evade the immune checkpoint inhibitors by expressing PD-1, PD-L1, CTLA, TIM3, and LAG3. That is why the immune escape phenomena in HCC is very high. As compared to RCC, that is the renal cell carcinoma, which responds beautifully to immunotherapy. This immune escape is not seen in renal cell carcinoma as much as seen in the HCC. So why do we combine this? Well, there are multiple theories as they go forward. The bevacizumab will promote the dendritic cell maturation. Once that happens, this will cause the dendritic cell will promote the T cell activation by allowing the B7-1 co-stimulation. Also, bevacizumab being an anti-VEGF will normalize the tumor vascularity, thereby increasing the T cell infiltration, and also it decreases the activity of the immunosuppressive cells which are there. So atezolizumab restores anti-cancer immunity, which is very, very important. So knowing all this, let's go into the IM-Brave 150 trial, which is a phase 3 trial. And it's a trial, but I think we are all using this in clinical practice now with the results which are there. So this showed that it was a phase 3 trial, locally advanced or metastatic or unresectable HCC with no prior systemic therapies, all first line, were given atezolizumab 1200 milligrams IV Q3 weekly, plus bevacizumab 1500 milligrams per kg IV Q3 weekly, versus the standard of care which was existing, that is sorafenib 400 milligram orally twice a day. And this was a 2:1 randomization, and the patient was followed up until loss of benefit or unacceptable toxicity, and the survival follow-up was done. What was important in this study was the Asian, excluding the Japanese and the rest of the world, were there. And importantly, the MVI and the extrahepatic spread, presence and absence, was studied. Also, since majority of the patients are high-risk patients, where you have the invasion into the portal vein or the bile duct, or more than 50% liver occupying disease, 20% of the patients in the study were high risk. The baseline ALP of less than 400 and more than 400 was also studied. The co-primary endpoints were the progression-free survival and the overall survival. The key secondary endpoints were the overall response rate and the IRF assessed as per the RECIST criteria, which was as per the radiological findings. So as you can see, both the groups were very equally matched when it came to all the parameters, whether it may be the ECOG, the child pug, the BCLC. But importantly, the majority of the patients were the viral hepatitis HCC cirrhosis leading to HCC. Also, another individual thing which I said, the high-risk individual where the extrahepatic spread or the invasion into the portal vein were very, very high, and 20% of the patients were definitely in that category. So the first co-primary endpoint was the progression-free survival, and at 6 months itself, that is 6 months after treatment itself, there was a difference in the progression-free for the survival, 55% versus 37%. Though the median overall PFS was only 6.8 versus 4.3, but this was the first time we were getting responses in a patient of HCC, and this was the first analysis which was done. As you can see, the graphs still keep a fair distance as they go forward till 12 months and again at 15 months. So a follow-up systemic therapy for HCC again showed that individuals who received atezolizumab plus bevacizumab, lesser patients went into second-line or third-line therapy. So they continue to reap the benefits of the first-line therapy. Also, the type of therapy which was used in the second-line therapies was definitely chemotherapy or IOs in the atezo-bev arm, But see, in the patients with sorafenib arm, majority of the patients went into either a TKI or immunotherapy. So they had to be given immunotherapy. So why not keep immunotherapy for the first line? So I Am Brave 150 overall survival also met its primary endpoint at 6 months, 85 versus 72 months, and was the survival, which was again statistically significant. As we know with immunotherapy that even after we stop the immunotherapy, we enjoy the sustained response of immunotherapy. The overall survival also depicts the plateauing as it goes forward following 13 to 15 months, which is there. And this is the important thing that I want to highlight, the updated overall survival at 6, 12, 18 and months continue to be good, 85 versus 72, 67 versus 56, and 52 versus 40 months. So the median overall survival, if you can say, is 19.4 versus 13.4 months, unheard of in HCC so far. So all the various subsets with the immunotherapy anti-VEGF enjoyed a benefit, as you can see by this plot, which is there, except somehow the BCLC stage B, which did slightly better with the tyrosine kinase inhibitor. The reason for that probably I can't explain, I don't know. But the PFS was better in all subgroups when you came to the IO bevacizumab arm. What about the overall response rate? Look at the overall response rates which are there. Individuals, 18 patients attained a CR. 71 patients achieved a PR. So the overall response rates were extremely good when it came down. These were again statistically significant. So not only are you basically, if you get a good response in such individuals, you can probably try local therapies in these individuals also and enjoy a benefit of the benefit that you harped from the IO anti-VEGF inhibitors. So once again, these are the updated analysis. CR, PRs much better as compared to the tyrosine kinase inhibitors, which were seen as per the RESIST 1.1 as well as HCC RESIST criteria. This is what we should always look at. What about the DCR? What about the individual with stable disease? Again, with the atezo arm, it was much better. So what about the safety summary? Yes, there are toxicities of immunotherapy which are there, but so are for tyrosine kinase inhibitors. As you can see, there were adverse effects, but look at the grade 3 side effects which are there. Well, they're almost comparable. In fact, in some cases, the grade 3 side effects are more with the TKIs as compared to the IO bevacizumab arm. Diarrheas, decreased appetite, hypertension, everything was more in the sorafenib, except hypertension and what you call ALT proteinuria, which was higher in the IO bevacizumab arm. The sorafenib arm had toxicities which were high, which was seen. As compared to the lenvatinib, sorafenib, and then sorafenib atezo-bev, we know that in these individuals will develop varices that may require treatment. But over a time period, as you can see, all three arms had equal numbers which were there. So bevacizumab did not actually cause that. What about bleeding? Well, variceal activity assessed before the therapy and thereafter, we found that individuals had few varices, but none were grade 3 or 4. Negligible numbers were grade 3 and 4. Hepatitis at diagnosis, well, again, they were almost equal, 21 and 17, which were there. So if you see the atezo plus bev versus sorafenib, when it came to even hepatitis, they were. So now it comes to the last three things: the quality of life, functioning, and the symptom: fatigue, appetite loss, and diarrhea and jaundice with the combination. As you can see, the quality of life was much better, 11.2 versus 3.6. And this is the patient-reported quality of life or the deterioration-free rate which was there. So these individuals had a better quality of life. Like I told you, sorafenib, not a very friendly drug, not well tolerated by our Indian population. What about the deterioration-free rates? Other side effects, again, 13.1 versus 4.9 months. The IO-VEGF combination did better. And again, 9.1 versus 3.6 months, which was there. So the patient's perception of their well-being, which is very, very important in any disease and more importantly in oncology, was much better in the IO plus VEGF arm. And I think these are beautiful graphs, which I think should be done in all our patients to see that what is the patient's perception of well-being and quality of life. Deterioration of symptoms can also affect the patient, yes, but the deterioration with diarrhea, fatigue, jaundice was though higher in the IO bevacizumab arm, but these individuals preferred still the atezo plus bev, which was there, as you can see from this graph. So what is the systemic therapy for HCC in 2021? So these are old slides. Atezo-bev first line, sorafenib we hardly use. Yes, lenvatinib we use. And the second line therapy is the regorafenib, cabozantinib, ramucirumab, especially in those where the alpha-fetoprotein is more than 400. IOs is a talk for another day as we go forward. The other IOs. And this is what I think everybody should know. The HCC should be first told whether it is resectable or transplantable. If it is resectable or transplantable and Child-Pugh A and B, resection or local therapy should be given. Or by UNOS criteria, if the patient is transplant eligible, he should achieve transplant. If none of this happens, the patient is not a transplant or a resectable candidate, loco-regional therapy should be given and systemic therapy should be started. Even in individuals with bulky metastatic disease, the treatment is systemic therapy. I think the first line therapy should be an IO anti-VEGF from the study that we've seen. So once again, a repeat of what we say, and this is what the ASCO guidelines also say, that you should go for an IO anti-VEGF combination for HCC and keep tyrosine kinase inhibitors for individuals who are probably not eligible for the above combination or as a second line therapy, which is there. And this is the Europe or the ESMO guidelines. And for once, the Americans agree with the Europeans, and together they also say that the combination is the preferred option for BCLC stage C disease, which is there. So I conclude by what I said, that atezolizumab plus bev demonstrated a statistically significant improvement in the overall survival, progression-free survival. More importantly, it showed a better quality of life, physical functioning, and acceptable and manageable toxicities which were there. Yes, cost is a big factor when it comes to our patients of HCC, especially when individuals have exhausted all their monies on alcohol and got cirrhosis. They hardly have money for atezolizumab, bevacizumab. But jokes apart, I think the combination has shown promise as we go forward and should be given. So this is the prescribing information. I'm not going to it. And thank you once again to the organizers. Thank you, Rajeshwar sir, and thank you, Rosh.
Thank you, Rahul. That was in fact, masterclass, clarity of thought, and wonderful presentation. I know it is a very difficult disease. TKI our patient do not tolerate TKI. So very difficult to give TKI in this patient, and with this combination, patient are living for longer duration without too many side effects. Thank you very much. And now we proceed to the most important talk of the day, that is extending survival in advanced urothelial cancer by Professor Kunal Jain. He is from AOI Ludhiana. He will be giving this talk. Dr. Kunal, please.
Good evening, everyone. Thank you, Rajeshwar sir, for this opportunity. And just passing comment for the previous presentation, it was a very good presentation. Just that we will have one more option, durvalumab, and will be approved for HCC with the tremelimumab. So single dose of tremelimumab with durvalumab. So
Roche has come with one more drug, which is triplet now with their,
they're making like
tremelimumab or something like that. It came in this ASCO, this was presented.
So.
Okay.
I'll just, so my job over the next few minutes is to discuss about urothelial cancer, and I hope the slides are visible.
Yeah, they are visible.
The final presentation before we conclude or say good night is with the excretory system, which is the good sequence for the presentation for today for IOs. So this will be basically focusing on the advanced urothelial cancer. How can we achieve better survival in addition to the conventional chemotherapy? So this is the outline of the talk. Urothelial cancer is the sixth most common cancer among all cancers in the world, and in Indian data, it is the 17th most common cancer with 21st number in terms of mortality. And these are the data from India, where various registries, they had recorded the number of cancers, and there has been a widening gap between males and females in India, where much higher incidence in males as compared to the Western population. We know that it is a difficult disease again, like HCC, not very many options. Although initial chemotherapy shows good response, but patients developed resistance, and also we are kind of lacking in terms of further lines of therapy after the initial platinum-based combination. So if somebody has metastatic disease, the 5-year survival is less than 10%. And on an average, the survival is about 13 to 14 months. That is what we use to conventionally quote to the patients. Majority of the patients in the Western setting, and even in our setting initially, may present with the organ-confined disease in the bladder, where they may have in situ or localized disease, where TURBT or local therapies may be utilized. Some percentage of patients will have regional disease, and a small proportion in the Western population, in fact, present with metastatic disease. Whereas I would say the number of patients with advanced, locally advanced or advanced disease in our setup is higher than 5%. And majority of the patients, even after metastatic, after cystectomy, will have relapse, distant relapse. And that is why there is discussion about neoadjuvant chemotherapy before cystectomy, especially in patients with muscle-invasive bladder cancer.
Yeah.
So majority of the patients will receive platinum-based therapy in first line. And those who are cisplatin eligible, they will have a combination of gemcitabine with cisplatin, or if they are ineligible, then they will receive carboplatin in combination with gemcitabine. And various factors which help us to determine whether they are cisplatin eligible or not are patients' renal function at the foremost, their performance status, any coexisting neuropathy, ototoxicity, if they have hearing impairment, and of course, if they are elderly. So we would possibly avoid cisplatin in these scenarios. So as previously mentioned, somebody who has a heart failure, where we are unable to give a lot of fluids, we may not be able to use cisplatin again. And the cutoff for GFR varies from 50 to 60, but 60 is a safe cutoff. Anything above that, we can easily give cisplatin, but anything below that, or definitely less than 50, we should consider using alternative carboplatin. And if it is very low, then we can consider these patients as platinum ineligible. So for those category of patients, pembrolizumab is the only drug which has shown benefit in patients who are cisplatin or carboplatin ineligible. So how can we extend survival? That was the main question of this talk. So various strategies can be, once we have given first line therapy, which is the standard therapy with the gemcitabine platinum, or if patient is extremely fit, then MVAC, but I haven't used MVAC or dose-dense MVAC in any patient recently for metastatic disease especially. So first strategy can be wait and watch. Once we have given the first line therapy, wait and watch till they have further progression, and then consider for second line therapy, which again, we are lost in terms of what to use in second line therapy. Other strategy could be continuation maintenance, especially if we have used IO in the first line in combination with the chemotherapy, then stop chemo and continue that IO. But that strategy, as we will see in subsequent slides, has also not shown to be of great promise. And the third strategy is switch maintenance, where initially we have given chemotherapy, and then once we select those patients who have shown some response or stable disease and consider those patients for switch maintenance with another form of therapy, which is an IO, which is avelumab. So we will go one by one. We'll see that first line therapy, as I said earlier, there are patients who will show good response. 50 to 80% of patients will show some disease control, but overall survival slightly better with cisplatin, but in the range of about 13 to 15 months. And if we consider the second strategy of continuation maintenance, where initial regime was chemotherapy in combination with IO, there are multiple trials, the IMvigor 130, Keynote 361, Danube, and LEAP 011, where no chemo is used, only pembro and lenvatinib. All these are negative trials which have not met their primary endpoints. And this is another trial which is recruiting patients still, and we do not have the last I saw was in ASCO 2022, I think, and I'm not aware of the results that have been reported. So this is basically looking at a conventional chemo combination with gem platinum and 1:1 randomization with an antibody drug conjugate, which is enfortumab vedotin, with immunotherapy, and seeing whether it is better than conventional chemotherapy. So till we have those results, the current strategy that has shown promise is giving initial chemotherapy and then selecting patients with response or stable disease to switching to avelumab, which has shown significant improvement in overall survival and also progression-free survival. So this strategy is basically called switch maintenance, and this has shown to be of positive study only in avelumab with Javelin Bladder 100, whereas the other study with pembrolizumab was did not prove to be of did not prove survival benefit. So as I been showing in the previous slides, the initial two strategies have not shown any benefit, whereas we now have Javelin 100, which has shown benefit of switch maintenance. So patients who have unresectable, locally advanced or metastatic urothelial cancer with measurable disease are randomized 1:1 to avelumab 10 mg per kg every 2 weeks with best supportive care or best supportive care alone, once they have received standard first-line chemotherapy, which is either 4 or 6 cycles of any of the combinations with gemcitabine, combining with either cisplatin or carboplatin. And after the initial therapy, there is a treatment-free interval of about 4 to 10 weeks and radiological assessment where patients who have CR, PR or stable disease were randomized into either of these arms, 1:1. And PDL1 was checked in these patients, but was not mandated. The initial OS, the OS was supposed to be studied in all comers and also to be reported in PDL1 positive patients. The way they tested PDL1 in the study was by SP263, and the reporting criteria was slightly different from how we usually see. They took either tumor cells, immune cells, and used 25% as the cutoff. So baseline characteristics, median age was 68, majority 3/4 were male. All will have good performance status in any of the trials. 55% of patients had visceral metastasis, kind of even break in gemcitabine cisplatin, slightly more than gem carbo, but kind of similar proportion. So somebody who has good performance status, obviously, and with fulfilling our criteria, we will tend to use cisplatin in that population. So what this trial showed that there was significant improvement in overall survival, where by about 24%. So the risk of death reduced by 24% in patients who were given avelumab maintenance as opposed to best supportive care. So we can achieve median survival of about 2 years, where we were talking about 13-14 months. So with the avelumab maintenance, the in all comers, and it was not shown in this presentation, but if you see the initial NEJM paper in 2020, the patients who had PDL1 positive subgroup, their OS was not achieved by the time this study was reported. And in those patients who had PD-L1 positive, even in the best supportive care, the survival was slightly better. It was about 17 to 18 months. Showing that PD-L1 positive patients may behave slightly better anyway in comparison to patients who are PD-L1 negative. So if we talk conventionally, at the 2-year mark, the survival was about 20% in 1990s. And if we are talking now, even at 3 years, more than 1/3 of patients who are on avelumab are surviving and continuing avelumab maintenance. And if we talk about PFS, that also doubled, more than doubled, from 2.1 to 5.5 months. And the hazard is 0.54, more than 50% reduction in risk of progression. And this hazard and the number was kind of similar if we talk or take the PD-L1 positive patients. It was 5.7 and 2 months. So similar or slightly more benefit in patients who are PD-L1 positive. So very small font. Apologize for that. The slides have been provided by Mark. But what basically this forest plot is showing that overall survival was longer with avelumab best supportive care across all pre-specified subgroups. So here there is a category of PD-L1 positive, negative, and unknown. If we can see, the PD-L1 positive is slightly better than the PD-L1 negative, but both are in favor of avelumab with hazards of about 0.7 for negative as well. And important thing is, as was previously mentioned in the previous presentation also, how do we see the quality of life when we are giving longer treatments? So obviously we feel that if the disease is controlled for a longer duration, their symptoms are controlled for a longer duration, their quality of life will hopefully be better. And this is what was shown. There was not significant difference in terms of deterioration in quality of life with added treatment with the avelumab. And there is an Asian subgroup which was about 21%. 1 in 5 patients were from Asian subgroup, and they showed that they were, in fact, they did even better with this strategy of switch maintenance with avelumab, with median PFS of 5.6 months and median overall survival of close to 29 months, as opposed to 23-24 months of overall population. So there are various questions, as was being previously mentioned also. When do we, like for durvalumab for lung cancer after CTRT, when do we start durvalumab? How many cycles of chemotherapy are sufficient, whether 4 are sufficient or 6 are sufficient? So what this trial basically showed, that irrespective of giving 4 or 6 cycles, irrespective of using cisplatin or carboplatin, the avelumab maintenance was beneficial in all of these subgroups. And when to image is again individual kind of preference. We usually tend to scan after 3 cycles or sometimes after 4 cycles, but the strategy of scanning after 2 cycles will be kind of more aggressive. And if the patient is, the only benefit I see of this strategy is if the patient is continuing to show benefit after 4 cycles, let's say scan after 2 cycles, showed response, and after 4 cycles shows further response rather than stable disease, I would be more inclined to give 2 more cycles if in patient who is showing continued response, rather than switching that patient to another therapy with the maintenance avelumab. So again, showing whether it was 4 or 6, the benefit was kind of proportional. Whether the patients had complete response, partial response, or stable disease, the amount of benefit was kind of proportional across all the subgroups. And even the patients with CR are at risk of rapid progression, as was evidence in this group, that patients who achieved CR with chemo also had a shorter further progression-free survival. So which again raises the question whether even if they have achieved CR with chemotherapy, they should be considered for some other therapy to maintain that CR or maintain that response. So the treatment-free interval that was kept in this study was 4 to 10 weeks, and then the patients were randomized. So that is the time when we can plan for the scan after about 3 to 4 weeks, and then select the patients who can be considered for avelumab maintenance. And the purpose of showing this slide is basically how the patients fall off from first to second to subsequent line of therapy. So if we take 100 patients, only about 50%, 48 to 50% are able to receive some form of therapy or first line therapy. And out of that, only about 1/3 will receive further second line therapy, and even smaller number to receive third line therapy, which again, we are at a loss as to what to give in second or third line. Taxanes are one, sometimes pemetrexed, or sometimes we tend to go back to the similar gemcitabine if the responses have been durable and a longer duration has been achieved. So again, showing that whether carboplatin or cisplatin is the comparator or the combination with gemcitabine, the benefit is kind of similar. Slightly more with the cisplatin, but it is kind of comparable. And again, in some of the previous presentation, it was mentioned that the trial selection is quite stringent. Are we able to translate that benefit in real world scenario? So this data basically showed that it was kind of comparable, with median overall survival reaching close to 21 months with avelumab in real world scenario. And this is showing that 47% of patients were exposed to avelumab for more than 6 months. And with increasing timeline, the proportion of patients on avelumab was obviously decreasing, but was higher with PDL1 positive population as opposed to overall population. But still, almost 1 in 5 patients was on avelumab even at the end of 2 years. And in terms of safety signals, there was nothing different from other immunotherapies. 10 to 11% of patients had to discontinue treatment due to treatment related adverse events. So with this study, it basically established as one of the strategies for managing patients with advanced urothelial cancer. So what do we do for second line treatment? There are other medications which are mentioned, like enfortumab vedotin, which is again not available in India. It has to be imported, and we tried to get it for one of the patients, and it is hugely expensive. Per month therapy would have costed somewhere around 20 to 25 lakhs. It is a weekly dosing, and again, we were unable to get that. Erdafitinib is basically for FGFR mutation or rearrangement positive patients. And this is, I had used it for one of the patients, but by the time we were able to access this on compassionate access program, it took almost 9 to 10 weeks by the time patient had significant deterioration in function. From this study, it basically is showing that patients who were on best supportive care, 1/3 of patients were not able to get any form of second line therapy. So again, highlighting the importance, like we used to talk about lung cancer, that patients fall off very quickly. That is why the role of maintenance pemetrexed came, and maintenance strategies came. So that is a strategy we are using in bladder cancer as well. That is a similarity I can think of. So the second line therapies, erdafitinib, especially in FGFR selected, good response rates close to 60%, but it is a limited subset of patients. And I'll just quickly go through. Enfortumab vedotin, I have mentioned already that it is shown promise, and we will have more data with EV302. And in patients who have progressed after chemotherapy, one other strategy can be using pembrolizumab, the single agent immunotherapy, which has shown to be superior to combination or other types of chemotherapy in Keynote 045. So guidelines recommend, if patient is cisplatin eligible, consider this patient for gemcitabine cisplatin for 4 to 6 cycles, and then consider for avelumab maintenance. If ineligible for cisplatin, then gem carbo, and if completely platinum ineligible, then can be considered for pembrolizumab single agent. And these are the various guidelines which endorse that avelumab can be used as a maintenance strategy. And by using avelumab as maintenance strategy, we can achieve the maximum overall survival as opposed to wait and watch or using IO in the first line. So with that, I'll end and just reinforcing that with this Javelin Bladder 100 trial, which was published in NEJM 2020, this has kind of established avelumab as one of the strategies for managing patients for advanced urothelial cancer. Thank you.
Thank you, Dr. Kunal. It's a difficult disease, bladder, and one disease where immunotherapy is not showing very, result better than chemotherapy. In fact, this ASCO also, they had dose dense MVAC, which was better than GemCis. We have now for maintenance at least one drug. Thank you very much for your presentation. Now we conclude in this. I'd just like to thank all of you, all the speakers who were there, who lovely presentation they had. I want to thank the Roche, Merck, and MSD who sponsored today's presentation. And of course, I also want to thank Tarun and his team from Cancer Research and Statistic Foundation from Horizon also for such a lovely presentation where we could meet and discuss two important, with these diseases. Thank you very much. And back to Tarun or Horizon for your final.
Thank you, sir. Thank you, everyone, for joining. And good night, everyone.
Thank you.